work has gone into this webinar and how much effort everybody has put into it. So thank you all for listening in and asking some great questions. You've kept me incredibly busy actually, because there are a lot of questions. So we'll start off for a question to everyone, and that I thought was a really great question. It was asking about, are universities now introducing remote rehab when training our physios, OTs, speech therapists, nursing, doctors? Does anybody want to answer that?
I can. I know that I've had some conversations with Coventry Uni and some lecturers at Nottingham Uni, and I know that they have signed up to listen to the webinar, and I think that they're really interested in how they can use remote working with student placements, like Sarah said, and with supervision. So when I know I work in the community, and sometimes it can be like the next step to let a student go into the house alone, but actually if you were able to do that remotely, it just opens up another way of supervising. So I know that they're really interested, but as with everything, it does take time to bottom out how to do that, and how to like the evidence base is just starting to come alive at the minute, and I think it's really exciting, and I know the lecturers I've spoken to are really excited about introducing that element to their course delivery. So, and I think they realise that it's efficient, it's just an efficient way of doing things.
Totally. And access as well, you know, we could potentially offer a placement in Rotherham to somebody in Liverpool, for example.
Yeah.
So, I've got a really great question from Joe B and Priscilla. They kind of asked the same question, so I'm going to combine it. And it was about access to people who aren't digitally literate. And potentially by moving in this way, we could be creating some sort of health inequalities. So I don't know if Nat or Sarah would like to answer that. Liana's desperate too.
So I've even carried out therapy over the telephone. So some people have struggled with video calls, but I've been able to kind of carry out the therapy that I've needed. So aphasia therapy and dysarthria therapy over the telephone. And it's actually worked really, really well, because that's even sometimes a barrier for people with communication difficulties, is actually talking on the phone. So carrying out the therapy over the phone, definitely kind of it's working in speech and language therapy anyway. Even have carried some swallow assessments out over the phone as well, which have been a bit more challenging, but it opens up kind of, like you said, those kind of barriers to other people. But I do think in the future, when we're more thinking about kind of face-to-face versus telehealth, that's probably what we do need to kind of think of, the equality, and would a face-to-face be better for that person, whereas then telehealth might work with another person, and it's just making sure they're getting that equal treatment.
I would agree with that, Sarah, because I think that's why the research is needed alongside deployment of new technologies, so that we understand what works for who, when, where and how. And doing the research and doing a lot of service user engagement with it helps you understand what the barriers might be for people. And we tend to make assumptions about what people will or won't cope with, or who may manage technology and who may not. And actually, when you come to the service user engagement with the research, you realise actually some of your assumptions aren't quite right, and you learn new and different insights. So it is important to have that element and get that feedback when you deploy new technologies. And just touching on the last question as well, we've got 4 projects in the Netherlands where we've got universities and OT students trialling out the Viva technology in different clinical settings as part of doing their dissertations. So they're already starting to think about our future healthcare professionals and how they might engage with technology as part of their programme. So that's really exciting.
I definitely agree, and I think this pandemic has increased a lot of people's access. I know families have really been setting their relatives up with equipment so that they can still communicate with them when they're shielding. I think that there was some research by an author called Safo who looked at inequalities in terms of remote rehab, and said that actually on the flip side of decreasing access, but there was some hidden costs related to having to come to clinics and to access therapy and equipment. And actually telehealth can increase the access for those types of patients. It's also when they need long-term therapy, and I know especially with ESD, our patients may only get 6 weeks of rehab, and actually if we're able to provide these types of clinics and check-ins and 6-month reviews, it will increase capacity for community stroke teams. And I know that we've done sessions where we've done full sessions just setting someone up with our rehab assistants helping, and there is a scope for peer-to-peer, so upskilling our patients to then be peer-to-peer supports for people to set up remote technology. So there's lots of ways of increasing access, but it definitely is an issue. And also the Stroke Association, they provide grants if people need things for their rehabilitation. So there are ways if teams are willing to explore them.
Okay, the questions are just flying in. That's a really good sign. You know, when you've had really good sign. So quite a few questions coming in. Is this just stroke specific, or can this be applied to other conditions? Just remote rehab in general, but also your network, Liana, as well. So kind of two veins to that question, if you can all answer.
Who wants to go first? Shall I go first? I think the remote rehab platform is for all therapists, and the learning that we have on there is starting off stroke specific, but the ethos behind rehab is the same. If people are interested and there's enough interest, then we will develop other groups on the platform for different other types of rehabilitation, and that's really quick and easy for us to do. But I think the connection and the things that we can learn from different specialities is crucial. I know that I was trying to connect with some MSK physios around shoulder pain, because again, their techniques and what I learned as a junior is completely different to how you would treat some of those things now. So yeah, it's definitely open to all types of therapists who want to, in the whole MDT.
Yeah, when we set out with the Viva project, we started with the concept of remote home visits, but actually when we got to project 2, we talked to a whole range of health professionals, and they started to say, actually, I could see how using online video conferencing for consultations and interventions could be helpful for us too. And that's why project 3 is involving speech and language therapy, dietetics, different OT and physio services. So we definitely are expanding beyond our original remit.
I also agree, kind of tele-rehab, it just works fantastically for all rehab. So I'm working with people with progressive neurological conditions as well. And I suppose if we're thinking about the future as well, we know these people, they're going to have long-term difficulties, and being able to check in using kind of telehealth is really, really beneficial, that they might be able to get those few more kind of checks rather than having to wait on a waiting list for face-to-face. So it does work. I've used it with lots of different conditions other than just stroke, and it's been effective kind of with everybody that I have trialed it with.
Okay, I've got a question from, had everyone answered? Sorry.
Yeah.
Yeah, got a question from Emma Pilkington for the whole